is Charlie Hogan, and today I'm going to be performing a lung and thorax assessment and a cardiovascular peripheral vascular assessment. So I have my patient here, and we're going to start with the lungs and thorax. So first thing we do is we just look and make sure that the patient is not in any kind of respiratory distress. Signs that he would be in distress are retractions, his effort and labor is increased, but right now he has an even fall and rise of the chest, and I don't notice any kind of respiratory distress. I'm also going to go ahead and check his skin turgor. So go ahead and pinch up, and it should just automatically, and if it was staying up or tenting, that's a sign of dehydration. So there's that. And then after we've inspect, we're going to fill. So now I'm filling right up in here. I'm filling for any subcutaneous air trappings that he doesn't have, as any of that tender. Okay. And so nothing there, everything looks good. He's not in any acute respiratory distress. So now I am actually going to listen. I'm going to actually listen anterior and then posterior, because most of everything I'm going to do is going to be posterior. But first I'm going to do anterior. And I'm auscultating and listening with my diaphragm. All right, and I'm going to actually start above the clavicle here, and I'm going to use what we call the stepladder approach, and I am doing this so that way I can compare from side to side. And anytime I place my stethoscope on you, I just want you to take a deep breath in and let it out, okay? For the step ladder, I just drop down and then over. And that's the step ladder approach. It's just really nice in comparing. Very good. So I didn't hear any adventitious breath sounds. Some adventitious breath sounds that you could hear would be like crackles, wheezing, rhonchi. Crackles, they are often described as like crack and popple, kind of, oh my gosh, I can't talk. Crack, I'm sorry, crack, snap, pop, like the cereal, that's what I'm trying to say. And then they can be coarse. And then the wheezing is oftentimes associated with like asthma or any bronchial issues. And what happens is the air is getting constricted and is making a whistling noise when it's trying to get out of the constricted bronchial. And then the rhonchi is often really rough sounds. So I didn't hear any of that with him today. And then I'm going to go ahead and I'll do the tactile Venous on the anterior side as well as the posterior. What I'm going to have you do is anytime I touch you, I want you to say 99. And what tactile Venous is it's basically the vibrations of his words, okay? And it should, the point of this test is that it should be equal on each side. 99, okay. 99, 99. And these need to be 99. Intercostal, because 99. If it's not, 99. If it's not intercostal, then you're going to get dullness, because it's going to be over the bony areas and not over that. Okay, so we have listened anteriorly. Now we're going to do posterior. If you'll like sit in this chair with your back to me, so that way they can see what I'm doing. No. Step up for me. And I want your back facing the wall. Thank you. Okay, so same thing. We're looking first. Looking for the equal, the rise, the symmetry, everything is symmetrical. And then I'm also looking for any retractions. He has none of that. So now I'm going to palpate. Just let me know if anything's tender, okay? So, any tenderness? Nope. Okay. So next, I'm actually going to go ahead and just auscultate first, and then we'll do the palpation. You can do it differently, but I think for this video, this will be the best way. So, also going to start right here above for the anterior lung sounds, and I'm going to use the same approach, which is the stepladder approach. Okay? I'm avoiding the scapula. You want to always avoid, go ahead. You always want to avoid the bony areas. I'm trying to listen and talk, sorry. Okay, and fold your arms like this for me. And you can just stay like that, Ben. You don't have to move. Go ahead. Getting that right. It's important to listen to get all the lung sounds. No adventitious breath sounds. Everything was clear. He's obviously not in any kind of respiratory distress. So let me go ahead and we're going to do tactile Venous again. Go ahead.
99. 99.
So see how I'm avoiding that scapula there?
99.
Hold on, say it again, sorry.
99. 99. 99. 99.
Okay. All right, now I'm going to do what we call percussion. So I'm going to first just percuss and just map out his lungs. So what you do is you're going to take, I'm going to step in front of you, you can stay right there, behind that camera. I'm going to take the non-dominant hand and I'm going to place it just like this. And I'm going to take my dominant hand and I'm using the middle finger on both hands and I am going to take my dominant hand and hit the DIP joint in my finger. And what we're going to be hearing is we should hear resonant sounds over the lung fields because they're filled with air. And then if it's not, if we hear a dull sound, that's where it has ended. And that is because you should always hear resonant over the lungs filled with air. So I'm just going to map right now. So you're not going to be able to hear it. I got 3 taps in that one. So. Okay. Moving over. Sorry. You probably can't hear. And everything should always be equal. Okay, so now that I showed how to do percussion, I'm going to do what we call Diaphragmatic Excursion. And what this test is it shows how much the diaphragm is moving with full inspiration and full expiration. So what I'm going to have you do is I want you to take a deep breath in and hold it, and then I'm going to percuss until I hear dull. So go ahead, take a deep breath in, hold. I would mark with a pen if I had one, but right here is where we're at. It should be equal. Okay, so now that we've found the little area, what I'm going to do is walk up to where I find resonant sounds again. And that will be where we measure for his lung expansion. So if I had a ruler, I'd measure, but it looks like it is about 4 inches. And so it would need to be, it can be anywhere from 3 to 6. Some people that are real athletic can even be 7 or 8. And that just shows how much diaphragm is expanding with full inspiration and full expiration. So next, what I'm going to do is I'm actually going to do chest expansion. And the way you do chest expansion is I am going to take my hands and find the 10th rib and span them out, my fingers like this, and then I'm going to push in to where it's kind of pinching, and then I'm going to tell him to take a deep breath, and then my hand, see how my hands move? They should move, both of them should be symmetrical with their movement. So go ahead and release. So, and that is the chest expanding. Now, if one hand was, do it again just so I can demonstrate. So, okay, let go. If this hand moved up like that and this one didn't, then that would show that there is an issue. So, that is chest expansion. Next, we're going to do, I'm going to auscultate, and we are going to do some other exercises here. So what we would do these that I'm going to do next is I'm doing egnophy, bronchophy, and whisper. I'm sorry, this one is like French to me, and I can never get it right. Pertriloquy. There we go. And so what these are is you would do these on somebody that's maybe complaining of cough or their chest is hurting when they're coughing. So somebody that's maybe suspected of having consolidation or pneumonia. So what I'm going to have you do is I want you first to say 99 every time I place my stethoscope on you, okay?
99, 99, 99, 99, 99, 99.
So I heard real muffled 99, real muffled, like almost if I didn't know he was saying 99, I probably wouldn't even know that's what he was saying. And that's what you want to hear. If he had consolidation, you would hear 99 come through clearly. So he did not have any of that. Next, I'm going to do, that one was bronchophy. Next, I'm going to do the whisper I don't know who made that one up, but anyways, I'm going to do the whisper test. And what I want you to do is whisper 99 since we're doing 99. You could also do 1, 2, 3, but since we're doing 99, we're going to stick with it. So go ahead and whisper 99 each time my stethoscope touches you. 99, 99, 99, 99, 99, 99. Okay, everything was super bubbled. I really couldn't hear anything. If 99 came clearly through, that would be considered consolidation, and there was none of that, so he was negative for that. And then we're going to do the last one, egnophy, and which this one right here is, I'm going to have him say E each time I place the stethoscope on him, and it should be pretty much muffled E. If he had consolidation, it would be clearly E that you're hearing, or it could be E to what they call E to A sounds. So I'm just going to go ahead and listen, and I'll use my diaphragm still, and see what we hear. So go ahead, every time I touch you, just say E.
E, 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 E.
Okay, so no consolidation. So we are good on the lung and thorax assessment. If you will, go ahead and take a seat on the couch and lay on the pillow, and then go ahead and turn your head to the left. And come on up closer so she can see what I'm doing. So we're starting the cardiovascular assessment now, and I'm starting with the jugular. I don't have a bed to move, obviously, to an angle, so this is about a 30-degree angle. But I'm looking at the jugular vein right now. So we're talking about jugular venous pressure. We have the external jugular vein and the internal jugular vein. And an external jugular vein, which you can't see on my ear, but you could usually see the pulsation. Yeah, and I can actually feel it. So definitely can't see the internal because it's too deep, and really can't see the external. So to measure the jugular venous pressure, what you're going to do is find the highest point of that pulse. And you would take a sharp object. You can use a card, tongue depressor, anything of that nature, and find that highest marking. And then you would take your ruler, which I did not have a ruler, which is very sad since I have so many children and I didn't have a ruler, but I guess they're not doing well in math. And you would take your ruler and you would take that straight object and you would measure from here down, And that right there should be less than 3 centimeters. And Mike's is, you can tell. But that is how you would measure jugular venous pressure. Now, if you're having problems with finding the jugular vein, then what you're going to do is, if for some reason it's lower and you need to get it higher, you would lower the bed, which is really weird to me because it would seem like you would lift the bed, but you don't. So for low, low, and for high, you would sit the bed up higher. So that is that. Then I'm going to actually go ahead and move on, and we're going to do his carotid. So first things first, do not ever do your carotid simultaneously. You'll cut off the circulation to the brain. That's not good. And then also avoid the carotid, what we call the carotid massage, but it's the carotid lymph node there. And if you massage it, it'll bring down the blood pressure and heart rate. I'm not trying to bring yours down, but that is something you don't want to do. In fact, usually if a doctor's going to do it, they have a nurse come in the room with them. I'm usually one of those lucky ones sometimes. So you don't want to do that, especially when you're alone. So you want to avoid the area and you want to find the carotid. So, and I'm just palpating now for his carotid. See how I didn't do it both at the same time? That would be really rude to my patient here. But when you're feeling it, make sure you're not feeling any thrills. I'm not. A thrill can be described as like a cat purring. It's kind of like a vibrating type feeling when you're feeling. And the cool thing about the carotid is when you are palpating it and feeling, is the upstroke. The upstroke is happening right after the S1 is ending and when your S2 is beginning. So if you have a patient who's having a real high heart rate, you could listen and feel at the same time, so you could feel the S1, S2, kind of have more of an idea. Next, when you're doing a carotid, what you're going to do is listen with your stethoscope, and you're going to listen with your diaphragm and your bell. So this is your diaphragm, this is your bell. So first, I'm going to actually listen, and we're listening for bruits is what we're listening for. So I'm going to listen first with the diaphragm. Turn a little bit. And then I'm going to listen with my bell. And he has no bruit. If for some instance, Ben, you don't have to move so much when you're videoing. My son is the videoer today. He is doing a good job, but he is wanting to make sure he captures everything for me. If you were to hear a bruit, you could, once you move on and do your when you're listening for other heart sounds, you want to make sure that it's not a murmur that is, you're thinking that it's a bruit. Because sometimes murmurs, especially that aortic, can be sometimes missed and thought of as a bruit. So, didn't hear any bruits though. All right, so now we're going to move on down to the chest area. So first I'm just looking, okay? So when we're looking, we are looking for symmetry. You always want to look for symmetry. Is everything rising and falling symmetrical? And we already know it is from the lungs and thorax. It doesn't look like I don't actually see any pulsations at all. Sometimes you can see some ventricular pulsations, and I don't see any. A lot of times though, that is honestly with your very frail, thin patients, you can see them, but I don't see any on him. So then you could feel around, make sure he's not having any pain. Now, if something wasn't symmetrical or his chest wasn't rising and falling, don't start pushing around. That would not be good. But everything's fine. So if you'll come up over here, Ben, I'm actually going to have my patient sit up, and I want to make sure that she's able to see where I'm feeling. So I'm going to do some palpation. First, I'm going to palpate in between. We're going to do the right second intercostal space. And that right there is the aorta. Then we're going to move over second intercostal, pulmonic on the left side of the sternal border. Move down, third, okay, fourth, fifth. That right there, that is Erb's point, third through fifth. Then move over mid-clavicular, fifth intercostal, so we're just going to move over. And that right there is the point of maximal impulse. And so you should be able to feel here the pulse, lightly tapping on your fingers. And if you don't, I'm actually going to have you lie down again and roll to the left side. You should be able, this brings it down and you should be able to feel it if you weren't able to feel it. So that's just a little trick there if you're having problems. Okay, go ahead and sit up. So you saw where I had palpated and I did the landmark. So what I'm going to do now is just listen. So we've looked, we've touched, and now we listen. That's the way we should always do it. And I'm going to listen with my diaphragm first and then my bell. So let's go ahead and listen. And you're listening for S1, S2. You don't want to hear any S3, and we're just going to inch our way down here. You don't want to hear S3, S4, or split S2. I will say, that a split S2 can be normal if your patient is taking a really deep breath in, because that is causing those valves to close improperly. And so sometimes if that is occurring, that can be a normal thing. But he had S1, S2 noted, so didn't hear any S3, S4, or S2. Now I'm going to listen. I like listening with the. It's such a good, nice sound there. Okay. So we have now listened. Everything sounded good. Now I'm going to move on and do the upper peripheral vascular system. I don't know what it is about these videos, but I can never talk. I can never pronounce anything correctly or say what I'm trying to say the first time correctly. So first, we're looking. His color looks normal. Looking at his arms here, feeling no edema. It feels warm. Fingertips are warm. That's always good. Always want to feel the fingertips, of course, because that's where your blood flow is going all the way down to. So you want to make sure you're getting blood flow. Now for the cap refill, just blanch the finger. It should come right back pink. So it should go white and then pink. And he's less than 2 seconds, which is good. Now, I'm going to palpate the lymph nodes. Haven't been, is that tender?
Nope.
Any tenderness there?
No, ma'am.
Okay. My patient's my spouse, so we're actually both been cardiac nurses together, so he's probably deep down grading me too. But now I'm going to feel the radial pulse. And it's good to feel them together, because that way you can kind of just see, are they equal? Anyways, he's got 2+. 2+ is good, strong. 1+ is a little diminished, and 0, Houston, we have a problem. We don't have that problem today, though. And next, we're going to do brachial. Here. Very good, strong 2+. I did not palpate these together. And I'm going to do my Allen's test next. Sorry, I don't know if you can see what I'm doing. I'm feeling, because I couldn't feel this one at first. Kind of relax your arm a little bit there. All right, found it. Okay. Sometimes this can be tricky to find, and I'll also say if you're ever asked to pull a sheath on the brachial, it's always good to let somebody know, because when you're holding pressure, your fingers are real slippery on this site, so just a little free-for-all. Those can be really easily lost. All right, make a fist, tight fist for me. I am holding pressure on the ulnar and the radial. I am going to let the ulnar go. Well, after I have you open your palm, let the ulnar go. And it was blanched, and at 35 seconds, it was pink. Do it again. So, because I didn't demonstrate. I'm letting go of ulnar. Well, first open, letting go of ulnar, pink. Let's do this one. Tight fist. Holding pressure on my radial and my ulnar. Open your fist. It's white, it's blanched. Letting go of my ulnar. Pink. So good. And we actually use that test in the cath lab, because I never knew when we were going to use it, and then all of a sudden we use it, it's the way they decide if they're going to go radial approach during a workout. So that's one way we test that. All right, so no edema, no swelling. Hair distribution, very good sign when you're looking for peripheral issues in the upper extremities. And he doesn't have any, no swelling, no edema. So that is the upper. Now we're going to move on to lower. So actually, I'm just going to have you lay down. So femoral pulse. Obviously he's got shorts on, but you could palpate here. Everybody's femoral pulse. I'm sorry. Most of them are where they're supposed to be, but I've pulled a lot of femoral sheaths, and sometimes I feel like, you know, it's not always just right. So you've really got to find those, because especially if you are doing cardiac nursing, always find your femoral pulse. That way, in case something happens and they do come back with a sheath, you kind of have your landmark identified. We're going to start upper, moving down, feeling for edema. In your third spacing, he doesn't have any. He's warm, no coolness to the touch. Hair's evenly distributed. Everything looks fine there. Next, I'm going to do the Popliteal Pulse. These are hard to find. He bends his knee. You cup your hands, and then just inch them until you find that Popliteal Pulse. 2+. Next. Okay, 2+. Now, looking at the feet. Feet are wonderful. Hair, good. You remember, you know, this is where your circulation goes all the way down to. Usually if you're going to find an issue, you're going to find swelling around the ankles, sores on the feet, especially with diabetic patients that aren't healing. So if you do find a sore, he actually has a sore right here, I could ask him, hey, how long has this sore been here? If he's like, oh my, that's been there for forever. Hey, we might have a circulation problem. So that might need to be addressed. But actually, he got this today, so I already knew that. So that is not an issue. But making sure the toes are warm. And then the wonderful, wonderful pulses. The anterior aspect. I have found, actually, this one's 2+, which these can be very hard. Dorsalis pedis, anterior aspect of the foot. These can be really hard to find, and I have found that if you just don't even put hardly any pressure, you can find them a lot easier. But sometimes you just have to get the Doppler. Like this one, I'm having a really hard time finding. There we go. And a lot of times with these as well, it's a little different on everybody. So sometimes I've found them in weird spots, and you're like, what? And so you just mark it and keep going, because when you do have a femoral sheath, you have to find these pulses, because you have to make sure that they are getting blood flow. So you've got to know these pulses when you're doing cardiac. And this is your posterior tibial. And those are 2+ as well. Actually, those are really good. So anyways, just making sure that they're not having any vascular issues is super important. I can't even say important today. But you can also, if they're having any calf pain, of course, be aware of DVTs and all that good stuff. I'm big about DVTs. But any swelling, redness, but he has none of that. All his pulses were great. And this concludes our assessment for the day. So thank you.